Hello again. And our new topic will be the dermal sinuses, which can extend, as you probably know, all along the midline from the upper lip to the sacrum, and present different challenges according to their locations. This image is to pay tribute to Mildred Coding, who was the artist behind Donald Mattson in his famous pioneering book on pediatric neurosurgery. So first, as I said, we shall speak about craniofacial, occipital, and spinal dermal sinuses. All these lesions have in common one mechanism, which is a defect of primary neurorelation. They have also, they are very different according to their location, to the associated anomalies, to their presentation. And they have one common dreadful complication in common, which is the sepsis, and it imposes early diagnosis and prophylactic surgery. We have many different surgical techniques according to the different clinical and pathological forms. And one common surgical principle for all this surgery is to resect the lesion and restore the integrity of the protective layers. So the embryology, as I said, is a defect of the primary neurorelation. The closure of the neural tube occurs during the fourth week of after conception, and the neural tube becomes separated from the ectoderm with the extension of the closure on both sides. It terminates at the anterior neuropore around the 24th day, and the caudal neuropore at around the 26th day. If the ectoderm neuroderm separation fails, we can have either invagination of the epidermis, which gives the dermal sinus, or you can have evagination of the neuroderm, which gives the meningocele, or you can have both, like in this case, where you have a small lumbosacral mass associated with a fistula. It can happen in other places of the midline, as you will see. But we have spoken about the primary neurorelation, but the fistula can be associated with anomalies of the gastrulation in case because there is a domino effect from one stage of the embryogenesis to the next. And in case of diastematomyelia, neonatologic cysts, you can have an impact on the neural tube closure. And when you have abnormal neural tube, like in this case, who had diastematomyelia and a dermoid, and reciprocally, you can have a neural tube closure impacting the secondary neurorelation, that is the development of the caudal bud, and the next step, which is retrogressive differentiation, which leads to the ascension of the conus. And you can have, like in this case, a tethered cord due to a terminal lipoma in a child who had also an occipital dermal sinus. Then you have other processes like the development of the telencephalon, which will impact the occipital sinuses that we see, as we are going to see next, and the facial buds and the placodes, which will interfere with the presence of facial sinuses. So first, the spinal dural sinuses, which lead to this caricatural faunal tail. So what about the coccygeal dimple? It is not a dermal sinus. It is the gluteal fold is normal. It is symmetrical. At the palpation, you can feel at the tip of the coccyx at the bottom of the sinus. And if you do an ultrasound, which is not indicated in my mind, you will find that the fibrous tract goes straight to the tip of the sacrum, and you see that there is a large margin between the end of this fibrous tract and the bottom of the dural sac. And you have to convince the family that the coccygeal dimple is just a scar from the embryogenesis and the regression of the caudal appendage. It's a scar in the same manner as the navel on the other side of the anatomy. So the pathology of the spinal dermal sinus, you have the dimple, which is in the middle of a skin angioma. You have some hair around it, and the depth is variable. It can go down to the dura, to the pia, or intramedullary, and it goes either between the lamina or through the lamina, as shown here. And the intradural tract is often not epidermized, as you can see on the specimen on the right, and you may not be obliged to do an extended laminotomy in all cases. Often the conus is not low, that means that the sinus may be stretched over several vertebral segments. So the associated conditions, as I said, you can have defect of the gastrulation. So this is how it looks when you have neuroenteric cyst associated with a dermal fistula. It's very rare. Or diastematomia associated with a dermal sinus, which is less exceptional. And you can have other defects of the primary neurulation, as said before. You can have meningocele or lipoma, like in this case, associated with a low-lying conus. And also, you have associated conditions in the setting of a syndrome, like a Currarino syndrome, or other malformation, which are not known to be associated with a dermal fistula, but constitute as many orphan diseases which are still to be described. The distribution around the axial axis, the spinal axis. This is a series of patients I saw when I was working in Lille. I collected 31 cases, and only 2 of them were at the level of the cervical spine, 3 of the thoracic spine. The most important number were lumbar and then sacral levels. And the proportion of infected and non-infected patients were half and half. So the diagnosis was mostly made at birth because there was a midline mark with angioma, dimple, hair. Sometimes you can have an abnormal gluteal fold. Sometimes it's done later, in which case you can have a loss of chances, as we shall see. And it is different from the coccygeal dimple, as said before. It is at a higher level. There is angioma, hair, and sometimes abnormal gluteal fold. And when you try to mobilize the dermis, you see that it is fixated to the aponeurosis. It umbilicates when you try to lift the skin. You have other presentations and this ideal screening at birth. It can present later as a spinal mass with pain or stiffness in the child who does not complain of any pain but is completely stiff. Or it can lead to a neurological deficit with a sphincter disturbance. You can see on this MR the stagnation of feces and the very large bladder with thick wall, and it can impact on the kidney above, of course. And it can present with sepsis. It is the worst that can happen to children. It can be apparently superficial sepsis with purulent discharge, but in many cases you can have meningitis, empyema, or myelitis. This 9-month girl was not seen at birth because, as you can see, the fistula was extremely small, but she presented with a Staphylococcus epidermidis meningitis, and the pediatrician took a magnifying glass to see this the fistula, and the MRI showed there was an extension inside the spinal cord with an epidermal cyst. And so really, this is a very high-stake routine, and this is another child who escaped the initial screening at birth, and she presented at 8 months in emergency for a state of shock with an abdominal mass, which was in fact her bladder, and she was comatose. She had an MRI which showed a meningitis with a hypothesis of tuberculosis meningitis. She underwent an EVD. The CSF showed multiple bugs, and only at that time was her back examined, and we could see collection of pus coming out of this fistula. Unfortunately, it was too late for her, and she died. So these patients must be operated, and as early as possible. We do an orange wedge incision around the sinus. We dissect the subcutaneous tract down to the aponeurosis. We do laminotomy or laminectomy, following the tract through the different planes. We dissect, we expose the dura mater. We incise the dura mater around the tractus, and we can have a cyst intradurally. We have then a tether to the cord, which can be or may be not epidermized, and you can have a cyst inside the spinal cord. So this is an example step by step in a 2-month baby who had time to develop meningitis, unfortunately, before she was operated. And you see the skin dimple, you see the spina bifida, which was very easily dissected. Then we expose the dural sac by just splitting the spinous processes of the spine. We incise the dura mater above the fistula, then around the fistula to free the intradural tractus. Then it is dissected and removed, and the dura is closed in a primary suture. So this is not very complicated surgery, but it should be done early. This is another example in a cervical lesion in a baby operated at 7 months. She had an extension of the sinus to the medullary cervical junction. And now you see we have opened the dura. We are exposing the extradural tractus. We do some suspension of the dura. We can now dissect the intradural tractus, and we shall extend a little more the opening of the dura, just enough to expose the attachment of the tractus to the spinal cord. And now we are regulating and sectioning this tractus. So as I said, I collected 31 cases operated over 18 years, and the functional results were compared in infected versus non-infected patients, and obviously the infection was the cause of a high rate of morbidity in these patients, and even mortality, as I showed. So what are the risks of infection if the patients are not operated? This is the cumulated incidence of infection in these patients if they were not operated, and you see that by the age of 12 years, it's about 100% of infection if these patients are not operated. So these patients must be operated, and operated early, because infection is not a question of if, but when. Now we speak about occipital dural sinuses. As I said, it involves the development of the telencephalon. These beautiful drawings come from the work of Dorcas Hager-Paget and show the extension of the telencephalon between 18 and 80 millimeters, and the position of the tentorium in yellow, which comes from backward, and while the telencephalon wraps around the middle cerebral artery axis. So it sweeps any adherence between the epidermis and the neurodermic. So this is probably this which explains that there are no neural tube defects between the glabella and the opisthyon. And also it explains why when we dissect occipital sinuses, we often find that the tractus is embedded in the trachea, and this represents the main difficulty of this surgery. So Saito had proposed classifications of these sinuses because they do not always extend from the skin to the cerebellum. Very often they are incomplete and they stop at the dura or just inside. And you can have associated lesions. You can have a meningocele, like at the spinal level. You very often have vertebral fusion, which can have an impact on the growth of the child, of course, and you have a very short and stiff neck, like in this small girl. And you can have hemivertebra and unbalanced spine, like here. So what is the risk of meningitis? A long time ago, I did a review of the literature, which was rather extensive, with 88 cases collected in 2001. And the cumulative incidence of sepsis in these patients amounted to more than 75% of these cases with time. But I did not find at that time any case of infection reported under the age of 1 year. But more recently, we did an update from the Lille series on the occipital dermal sinuses, and we found that there was 20% of infection before the age of 1 year. So certainly these patients too should be operated early. And if not operated, the infection rate was 100%. So the diagnosis is mostly done at birth. You have, like at the spinal level, an angioma, a dimple, a tuft of darker, coarser hair, which is easy to spot at birth because the hair is very thin and scarce, and more difficult to spot later. You can have a meningocele like shown here, and sometimes you have a midline bony mass or bony spur associated with the fistula. Sometimes the patient can present because of a posterior fossa mass, which is the dermoid cyst, or of aseptic meningitis. It is the classical aseptic recurrent meningitis described by Mollaret a long time ago. But of course, you have also septic meningitis and abscess in cases which were not diagnosed early enough or not operated adequately, as I shall show. The imaging can show on the X-ray the famous hole-in-one, because you have a hole in the skin, the bone, and the dura mater. You have the CT scan, which can show in emergency a cerebral abscess, like here, and can be also useful to explore the spine, like in this case, to measure the inclination of in the different directions. But the main exam, of course, is the MRI, which can show the tract of the fistula from the skin to the dura. It can show signs of infection, and we should look for other lesions, like here we had a lumbosacral lipoma. The technique for the standard case is, again, to do an orange wedged incision. We have to anticipate extending the incision back caudally, because you have to follow the fistula, which can go very low in the posterior fossa. And you have to remove the bone around the fistula with drill, with gouge, or anything you like, to expose the limits of the penetration of the fistula in the dura mater. And you have to dissect the lesion from the dura mater, which is gorged with venous sinuses. So, as I said, the fistula can be embedded in the dural veins, and hemostasis can be difficult in some cases, requiring a number of hemoclips like here. And in the end, you terminate the dissection on or in the dura or in the cerebellum in some cases. But when you have an intradural cyst, the exposition, of course, is much more extensive. You do, again, a midline incision with an orange wedge, but you do a suboccipital craniotomy. You see here there is a discrepancy between the bone hole, which is much higher, and the transverse sinus, which is lower. That means that the trocula is in fact stretched over the fistula. Then you do the opening of the dura mater in a U shape or Y shape as you like, and you dissect the epidermoid cyst from the cerebellum. And in the end, you find it is attached to the fistula, which is then dissected from the venous sinuses, and you do an autologous duroplasty, of course. This is an example, a video from a case who had to, it was a redo surgery in a child who was not operated like she should have been, and she had a recurrent abscess, and she had to be operated in the middle of the night in severe intracranial hypertension plus septic shock. So it was a very delicate situation. And this is when we do the dissection. Here you see the dermal tract, and you dissect on the side, and here you will find the plane where you can start the dissection between the shell of the abscess. And here, at the end of the dissection of the shell of the abscess, well, it's a bit bleedy, but nothing to worry too much. But you can dissect beautifully the shell of this abscess from the cerebellum, and when it is dissected, you can remove it totally. So this child had a good evolution after surgery. We speak now about craniofacial dural sinuses, and to illustrate, I took a classical sketch by Paul Tessier, who made his reputation on the craniofacial clefts. And here, the connection, as I said, is because of the impact of the fistula and its interaction with the development of the placoids and the buds of the facial skeleton. So I spoke about the anterior neuropod, which closes around day 24, and then the development of the telencephalon. These are again the drawings by Dorcas Hager Paget. And the facial buds explain why these dystrophisms will overlap with the clefts. This is the development of the different facial clefts. This is the attachment between ectoderm and neuroderm. And when the buds develop and join, they will take between them the fistula at different level, at frontonasal, frontoethmoidal, and columella. So we can describe three main types. Of course, all nuances exist between the frontonasal fistula, which is the upper one, the nasoethmoidal fistula, which is lower and goes more backward, so it can be associated with a dermal cyst, intradural dermal cyst on the crista galli. The columella, which is the lowest and the most complicated, and hopefully the rarest of these cysts, which goes even deeper and more backward. So, and can be associated with complex craniofacial malformation. And these dermal sinuses are often associated with frontal dysplasia, with metopism, with hypertelorism. And these are illustrations of Tessier clefts type 0 and type 14. So the presentation is, as the other dermal sinuses, a dimple with hair. Here we can have a widened nasal bridge. You can have a seronomass when the cyst is very low on the tip of the nose, and you can see that there is also an invagination of the fistula when you try to mobilize the skin over the nasal bones. And sometimes it comes with an infection which can be very severe. And in this case, it was a pseudotumoral lesions, which was taken initially as a sarcoma. Hopefully it was not, but it was. It needed a surgery in emergency, and in some cases you can have very severe neuraxis infection. So the surgical plan will involve an extradural time with an ENT or a plastic surgeon, or sometimes a neurosurgeon when we have to organize very fast in emergency, and a bitragal scalp in order to do a craniotomy between the two eyes on the frontomedial anterior frontal bone and hinged on the frontonasal suture. So there is a orange wedge incision around the dimple on the dorsum nasal. We do a subcutaneous dissection down to the periosteum, and then we follow the fistula up to the bone penetration. We do a bitragal incision, which is a long incision, but it is invisible because it is entirely in the hair. We do a subgaleal dissection of the frontal bone and periosteal incision between the temporal muscles. We go down to the nasal bone to identify the orifice in the frontal or nasal bone, and we rejoin the nasal approach. We do a frontonasal bone flap, which is very good application of the piezotome to do a very discrete incision on the bone. As I said, the bone flap is hinged on the frontal nasal suture, so it replaces very easily. Then we dissect the cyst, which is often embedded between the two layers of the dura mater. So there may be some opening of the dura mater, which must be closed. Hopefully there is no communication with the aerial cavities of the face because it is completely in the thickness of the bone. And then, after removal of the cyst, the bone flap is replaced with 2 stitches. So if we may conclude regarding the craniofacial fistula, like the others, there is a very severe infection hazard, but also a morphological impact. These lesions can be associated with other complex craniofacial anomalies, and they are operated by double approach. So to conclude on the different types of dermal fistula, these are very easily overlooked. It is very important to organize a very thorough examination at birth, not to miss any case. Preventive surgery is imperative, and it should be early before during the first year or even the first month. And in case of infection, it is an emergency because of the vital and major functional risk. I thank you for your attention.